Yep, so we can see everybody in the cloud. For those of you who haven't, I'm Catherine Haskins, and Brenda, you want to quickly say hello who you are? There she is. I see everyone's faces. We've got a few people that need to turn on their cameras. Great. Fantastic. I want to be the first to welcome you all to the Bridge Club. Woo! Yay! I wanted to go through a few things before our first host is going to begin the discussion. First and foremost, everyone's phone is unmuted. So at this particular point in time, if you have any background noise, we do encourage you to go ahead and mute your line. If you're not in gallery view, please put it in there so you can see how this actually looks with the community. It is up in the upper right-hand corner of your screen. We are going to be recording this, so this will be made available to others afterwards. But let me tell you first about the Bridge Club. The Bridge Club was founded by myself and Brenda Andreessen, who is on the screen as well. Wave, Brenda, just one more time so people all know you. We created this specifically to be TED Talks meets LinkedIn meets an old-fashioned book club, because we felt that the industry needed an opportunity to be inspired and connect with one another. This is a video-based community. This is meant to, so we can see your faces. We have learned that 93% of all communications is nonverbal. And in this day and age, we're losing that. So our intention is to really help inspire professionals, whether it's through professional content, personal content specific to the veterinary industry, or even 10% of our content is going to be on societal issues. So we want to make sure that this is a community that can truly engage. We have a very lofty vision, and today we're going to actually put that to the test with Dr. Werber and with all of you. So thank you for joining us. So it's now time for us to begin. Please get your beverages handy as we start. It is my extreme pleasure to introduce our very first host ever for the Bridge Club, Dr. Jeff Werber. Jeff, take it away.
Hey, well, first of all, I want to welcome and thank you both Catherine and Brenda for inviting me. And, just to start off the toast, pick up your beverages. At this hour in the morning here in California, it's 8 a.m. For some of you, it might be a soft drink. For some of you, it's at 5 o'clock somewhere. It might be really one of those good beverages. But anyway, I want to, this is my first hosting opportunity here, as well as the first hosting opportunity period for the Bridge Club. So I'm thrilled. I hope you can see my mug. Can everybody see my mug?
Yep.
It can. It says, and it's very appropriate for the subject matter we're talking today, and that is, please do not confuse your Google search with my veterinary degree. And if we're talking about telemedicine, telehealth, concierge, Dr. Google clearly has been practicing telemedicine for a long time, and we're allowing it. And so it's sort of become the norm. So I hope that today you can come away with some pearls to provide better care for patients and better bonding with patients and clients. And hopefully, of course, we all want to do this, make some more money. I'm just curious, since I can see you just by a show of hands, and you can raise your hands, right? How many of you just make so much money in the veterinary field that you could not even handle another few dollars in your bank account? Just as I thought. Okay, so clearly we have done a terrible job in utilizing our amazing talents and skills when it comes to how we charge. And my story is that I've been a concierge doctor for years. I started as concierge, and for those of you who don't know what that means, there are medical doctors that have been so disenchanted with medicine that many of the internists and general practitioners have become concierge doctors. They are charging, here in California, some of the fees they're charging, these are annual fees to be part of their practice, upwards of $10,000. Now, can you imagine just having, say, 100, you identify your top 100 clients, right? And you charge them each, your patients in the case of medicine, and you charge them each just to have them there, $10,000 a year. You haven't even touched medical anything, and you're already way ahead of the game. So, it's something that I've done. My clients have my cell phone. Back then when I started practicing, back in '84, they had my pager. Remember those pagers? I still have one, by the way. And I'm available 24/7. I do house calls. Obviously, my biggest house call is the euthanasias. But I want to be there because veterinarians are always complaining about not making enough money. And yet, when I think about how much money we give away because we're not there for our clients. Let's take the perfect example of the emergency call. First of all, how many emergency calls are not emergency? Let's face it. Probably 80% are not emergencies. But when our client calls and they're panicked because something's going on after hours, they don't know that. So what do? They call you. And what do you have on your phone? Hi, thanks for calling so-and-so vet group. And we're closed, but if you have an emergency, we want you to go to this emergency clinic. Well, that's just great. But guess what? Do they know it's not an emergency? Of course not. So they're going. And when they get to that emergency clinic, you can only imagine what's happening at that emergency clinic. And I know that just first of all, to walk in the door, upwards of $125, probably up to $175, maybe even $200, literally to walk in the door. They haven't even touched the animal yet. And so what's happening is we are giving our money away because they have that limp. Now, we all know how many emergency limps that we have, right? And all of a sudden, though, they have to, they want to take an x-ray because they're nervous. And most of the emergency hospitals are being manned by interns that just graduated in May. And so they're so nervous, they're gonna not, then they want to send it home with a non-steroidal probably, right? But of course, they don't know anything about this. So what do? They're gonna do a blood test, a full blood test on a 2-year-old dog because they want to make sure that Rimadyl is gonna be safe. So all of a sudden, out the door for $1,000 for the non-emergency, and then you see them a couple weeks later, and they need a dentistry. And you've been bugging them about dentistry for just months. And they look at you, Doc, I know the teeth are terrible. I didn't even let him kiss me anymore. But I get it. But Doc, I just spent $1,000 at the emergency clinic. And I got to wait. So doctors, people that are working with doctors in the group here, how can you complain? You're giving your money away. So, and how many of us take calls from clients even during the day? Right? They get you during the day. You have a little free time. So what happens? Right? How much money do you make when you are taking a call from a client and you tell them what's going on and they don't not having to come in? Right? You get nothing. So it's so important that we change our paradigm. We are doctors. When you pick up the phone and call your attorney, do they give you 15 minutes of free time or are you going to get a bill? When you call your accountant and they give you 15 minutes of time, is it free? But we as veterinarians have always given our time for free, and we deserve to get paid for our time. And so Concierge, and I call it telemedicine, telehealth. I see we have an expert in this arena is joining us as well, Dr. Lori Teller, and it works with the AVMA in this area of telemedicine, telehealth. And if we're not there to provide that service to our patients, they're going to go to Dr. Google, all right? And we lose every time. And there's so many misconceptions about telemedicine and telehealth. And do you think that these companies that are out there that are practicing, well, first of all, we have to understand the differences between telemedicine and telehealth and what we as veterinarians, as consultants could advise in the industry for what is the difference between telemedicine and telehealth. What are we allowed to do and what are we not allowed to do? And it all boils down to what's called the VCPR, the veterinary client patient relationship. Interestingly, there have been groups out there for years have been practicing telemedicine without a VCPR, and it's fine. And those groups are typically the emergency hotlines. And so they're getting away with it. And yet we, doctors who know a lot, should be able to get away with at least what we call telehealth. And I'm going to have Lori chime in a little bit, but the basic difference between the two is that with telemedicine, you're typically making diagnoses and treating. And I'm very happy that the AVMA and most of our state organizations are not in favor of allowing telemedicine. In other words, not having a VCPR and still making diagnosis. However, telehealth, I think, is really where it's at, where it's either we or somebody that we work with is available 24/7. Think of the millennial. The millennial is the fastest growing. In fact, right now, the #1 segment of pet owners are millennials. Now, I ask you a simple question. When that millennial calls and they want to talk to a doc, and that doc gets this, they get this from this, I'm so sorry, but the doctors are busy seeing patients now, or the doctors are in surgery now. Is that millennial satisfied? No. Where are they going to go? They're either going to keep searching, they're going to go to Google, They want an answer. They want an answer now. So we need to be prepared as veterinarians, as veterinary consultants, as anyone working within the industry, to make sure that our veterinarians know that they have to provide solutions to these issues. When that millennial wants their pizza, they are not going in the car and driving to the pizza place. We all know where they're going. They're going to their phone or to their computer, and they're going to tap in the pizza app, and they're paying for it, and they're okay with that. So we have to change our paradigm because we're so afraid to charge for the information and that which we do. And I can tell you that we shouldn't be, because clients are so appreciative and they want answers. They want answers now. And I think that's where we're heading with this. And I'm sure that any of your associates, any young doctors, I know they're not making a lot of money watching the football game at home on Sunday. But if we can give them an opportunity to actually do what they love to do, talk pets, educate, help, give advice, and get paid, that's where it's at. All right. Moms, 80% of our graduates across the country are women. Maybe, hopefully, they're going to have babies sometime. Maybe they already do have a family. And I just want to know, when the kids are napping, are they making money? When they're off for maternity leave, are they making money? But we can make money. We can actually provide veterinarians an opportunity to work even when they're not at the office working. So anyway, as I think my 10 minutes is up, and I really want to make sure that everybody sort of gets this whole concept of concierge practice, giving clients what they want, when they want it, getting paid for it, practicing telemedicine or telehealth. If it's your client, it can be telemedicine. If it's somebody else's client, because you want to be available and help, you can still get paid and you can provide a lot, because we know sometimes it's education. I do a radio show. I can't make a diagnosis to these people that call in, but you know what I can do? So you know what? It's interesting you say that. I had a case just this week that was exactly the same thing. It turned out to be whatever it is. So I'm not actually telling them that that is what their pet has, but I'm saying from experience, that is probably what it sounds like. And here's what we did. And this is not, you don't have to run to the doctor right now. You don't have to go to the emergency clinic. This is what I want you to try. You can try that. And then you could see your doctor in the morning. We're trying to sort of change our paradigm so we strengthen that bond with clients and their doctors, not somebody else's doctor, not Dr. Google, where we end up financially in better shape, and the clients are very happy because that's what they expect. They expect answers. They expect them now, and we have to be able to be in a position to do it. And I think this is the future of veterinary medicine. We're losing too much to Google. I am sure every one of us has had that client come in and say, "Oh no, I did a little search," and it's almost like they sensationalize everything. So every single patient who's got a little ailment, right, has, tropical pancytopenia. I mean, let's face it. You'll see that maybe once in a practice career, and yet that's what's going on. Anyway, I think, Catherine, should we open up for questions, comments, experiences we'd like to share?
Absolutely. So we got our first one that really wants to go a little bit more into that, honoring all the state regulations and all of the issues with regard, the policies with regards to the AVMA, and really securing that client relationship. Can you expand a little bit more on that?
Well, what I'd love to do, because we have, as I said, our very special guest is here on the line today, Dr. Lori Teller. Lori, can you hear us? Can you take yourself off mute?
Yeah, I can hear you. I'm battling a cold, so my voice may go in and out too.
Could you hear her?
I can hear her. Yes.
Okay. So Lori, you want to comment on this?
So the way the AVMA sees it is you do need to honor a veterinary client-patient relationship, but once you have established that by whatever your state laws are, and most of those state laws require a face-to-face exam or a visit to the premises, once that has been done, you can use whatever means you want to communicate with the client. You just cannot establish that VCPR through electronic or telephonic means.
So that means if we have the VCPR, we can go ahead, we can use our phone. Oh, that limp, let me see that lesion you're talking about on the skin, that golden retriever with the hot spot, because we know there are a lot of emergency hot spots that have to run to the emergency hospital right away, right? I'm joking.
I know.
And so we can use our phones, we can watch the limbs, we can actually see the, for one thing, and I always do when a patient walks in a room, I don't do anything, I don't touch, I just want to see the patient. I want to see the activity. I want to see the energy, because a dog who has an obstruction, for example, is not going to be running around, jumping up on the table, so happy to see me, right? So you can learn a lot just by observing. And then also let's for example, Lori, talk about for that patient that you do not have the relationship with, but you can make suggestions based on answers to questions that you ask. We call it telehealth. What's the difference?
Right. Correct. So you can provide very general information to a non-client who may contact you for health advice. So if they contact you and say their dog has diarrhea.
It definitely needs to be treated, because unfortunately you're not going to be able to tell what year the penny was ingested, what year the penny was made. So ideally I would induce emesis or get it out.
There's some telemedicine in action right there. Right?
So anyway, you can provide general information about various causes of diarrhea and advise the client if they need to see a veterinarian.
You don't get it out
if it's
but I would take radiographs first.
What some potential reasons are for it, but you cannot diagnose why that particular dog has diarrhea or how to treat it.
So in other words, there's a lot of different diarrheas, as we know. By the answers to the questions that you can ask really will determine whether or not this is something that needs to be seen now. And very simple questions. And as we all know as doctors, when the dog get into something, still happy, still eating, chowing down like crazy, not vomiting, the stool is a little mucousy, maybe even sometimes red blood, that's a big freak out. Large bowel diarrhea is usually not as serious as small bowel diarrhea. And yet what makes it so serious is what? They see that mucus and the frank blood and they panic. And dog can't wait to eat his next meal and running around like crazy. And, again, so these are things that we can advise that if the client, if it's an after hours call or during the day and they're panicking, they don't have to come in right now. We can make a suggestion, try to tell them what to do, and they can wait and see the veterinarian. My goal is, because there are most hospitals are not there 24/7. Let's provide 24/7 care, and it doesn't have to be them. It's, for example, we learn that to be successful as a practitioner, as a manager, as anything, we have to learn how to delegate. And in a sense, we can delegate some of these after hours emergencies to someone who is readily available, happy to do it, willing to make money. The patient wins, the client wins, we win, because we get to see our patient tomorrow morning, and yet without a problem. And that's kind of the issue.
So Jeff, we have a couple of other questions here too that kind of follow along with that.
Sure.
One of them is, so a lot of what you've been talking about is speaking strictly to those clients who have an existing relationship. So talk with us a little bit about how concierge medicine can apply to the pet owners who maybe don't have a veterinarian and they are going to Dr. Google because they don't know where to turn.
Okay, so there, we call that, as I said, that's, as Lori would mention, that's telehealth, where we're not allowed to actually make a diagnosis, and we have to let them know. Look, I can't tell you for sure, but let's talk about what's going on. So based on history, look, it's the same thing we would do on the phone with a client that we do know. And once we get a little history, we ask some questions, we get the answers to those questions. Any of us who practice for a while, I mean, for me, it's 34 years, we have an idea of what's going on and whether or not this is truly an emergency. Now, I work with a company that we offer those services, and my doctors know, because I write the protocols. If there's any question, remote question, that you're walking that tightrope, then you can send them. But we send them to the doctor's own emergency clinic that they recommend. So we work intimately with the doctor, with the hospital that are members. So we know kind of what they want, but we kind of stay in control. And again, we're working on the luxury that 80% of these emergencies aren't. When those people go to Dr. Google, clearly they're not an emergency, because Dr. Google can't do anything. So, and they'll come in 2 days later and say, well, I tried this because I read on the line. And so, again, if it's truly emergency, we'll know it. God, my dog is vomiting, can't keep anything down. His stomach looks like it's huge. It's growing by my golden retriever is growing by the minute, right? And he's getting weaker and weaker and more lethargic. Yes, that's probably a bloat or a busted spleen. Let's get him in right away. So but you can ask some questions. For example, lift up the lips and look at the gums. What color are the gums? Oh my God, the gums are white immediately. So there are a lot that we can do to give advice, but we cannot say, oh, it is this, and we want you to treat with that. I want you to go to your medicine cabinet, or we can't call a pharmacy and call in a prescription of something. But that's okay, because most of we know 80% are not true emergencies. So the goal is when that call comes in the middle of the day, people want to talk to somebody. They want to allay their fears. They're panicked. And our job, and we can, through just telehealth, just ease that anxiety. Let them know that's no problem. We call the office. They can see you this afternoon, and we'll get you in, but not to worry. That's all. Most of the time, that's all they need. They just want the satisfaction that they've talked to you or another medical professional, not Google, that they can actually get some questions answered, and we can make sure. So the end result will be the same, but doctors preserve their clients while they're on the phone. They're making money, and every opportunity that we can add to our bank account is usually very welcomed an opportunity in this day and age.
To that point, then, Jeff, how can we, or are there resources that can help doctors determine how they should price their telemedicine?
Well, nothing. I don't know, Lori. I don't know. I know Lori. AVMA has some guidelines. What we do is we know this. To walk into the door at a hospital, our office call is $69. If we do a telemedicine call or a telehealth call, then it's going to be $49. If they have to end up coming in, okay, we'll just charge them the difference. So either way, we're going to get our 69, but the goal is a lot of times they don't have to come in. They just want to talk to you. They have a question. So now we're getting paid. If you can take, say these are 10-minute calls. So you take 6 calls, you're making $200+ an hour. And I know for some of you, I know my lawyer laughs who charges me $695 an hour. And I understand from New York standards, that's pretty cheap now. There are lawyers out there charging $1,000 an hour. We're thrilled with the big smiles on our face that we get $200 an hour. So, but it's a way but clients are willing to pay. That's what I found the most intriguing. And as Lori will tell you, you would think that, well, by having the ability to have telemedicine or telehealth practice, it's going to decrease office calls. And guess what? It doesn't. If anything, it increases the office calls, because things that they didn't really think were a problem, now that you have them on the phone, you can say, you don't make it emergent, but you can get them on the phone and say, you know what, it would probably be a really good idea to do an eye stain on that eye. What's your schedule later on today or tomorrow or whatever it is? So it usually it can turn in, and often does turn into an office call, a full office call. And then you're doing other things, you're doing testing, etc. So I don't know, Lori, have you found that telemedicine does not hurt the doctor necessarily?
Correct. It's actually increasing client visits to veterinarians because they have the reassurance that they're doing the right thing.
So this perfectly tees up in another question between Jeff and Lori, the two of you. If there are any considerations being made with the AVMA with regard to exceptions to the VCPR. And, for example, when a diagnosis has already been made, and, can you work closely with the primary care veterinarian on, this is a specific case here that was noted, but it has to do with, for example, an 18-year-old cat with CKD who, okay, I'm not going to read all of this, sorry. But basically, are we not meeting our client and patient needs and exceptions with the VCPR instead of a blanket statement for how to establish it? I haven't stated that very well, so I would be happy to have whoever's posted this unmute, and it was Shay, and feel free to share a little bit more about your specific question, because I think it's an excellent one that both Jeff and Lori can maybe help provide some additional information on.
Thanks, Brenda.
Yeah.
I'm coming from the perspective of being a hospice and palliative care veterinarian. So for me, telemedicine, telehealth is extremely integral in the type and level of care I can provide to my patients. And what I find myself in situations is a patient comes to me with an established diagnosis, has been seen by a vet. They're saying, I don't want to do any more test diagnostics, come back to the clinic. And I'm not able to see them for maybe a week or two because of scheduling and availability. And there's a lot of things I can recommend to that client medically to make a huge difference for that patient in that interim when I can lay my hands on them. So I'm stuck between a gray area of I can really help, but not yet. And the patient suffers and the client suffers. And just simply as, using the idea of a chronic kidney disease kitty, we don't want owners to have to schlep in their debilitated, fearful cat for an exam just to get sub-Q fluids. And so I find that there's a lot of gray area and just wondering if exceptions could be made, or if we're thinking about making certain exceptions to the VCPR instead of just blanket statements on this is the only way we can establish it. And if you're not doing that, you're breaching, legal parameters of what you're allowed to do as a veterinarian. So I find trouble with trouble is not the right word, but I'm limited in what I can do because of the broad blanket statement.
Well,
so.
can I just, I'll just say this. First of all, there's nothing that you're going to be able to do anyway. The client can't do it for you. You mentioned sub-Q fluids. Once you go to that house as a hospice, like, for example, like lap of love type of veterinarian, then you can establish that relationship. You've had your hands on the animal. You could physically, there's very little advice you can give them anyway on the phone that's going to really help that
That's
cat.
not true, actually.
But you also can work with the doctor. The doctor who that pet belongs to, as far as the primary doc, they know that doc's in trouble. And I'm sure they've heard from their client that they're working with a doctor like you who does hospice and house call. So you probably can get a lot of information. And then, Lori, the question is, if that doctor is okay, who does have the relationship and gives this other doctor, in other words, is this like an arm of that doctor to go to the house or to do whatever they need to do and treat with the medication or recommend or prescribe something?
So a hospice vet would still need to establish a VCPR in order to do specific diagnostics or even just treatments if the diagnosis is already established. But you can certainly work with the referring veterinarian. So if the advice is to give sub-Q fluids, hopefully the referring veterinarian knows that anyway, then you can provide that, have that conversation with the referring veterinarian to advise the client until you can actually see the client.
So it's okay to work on the advice of the primary care veterinarian.
The referring veterinarian and the hospice veterinarian can work together.
Correct.
But the person who is advising the client with the ill patient needs to have an established VCPR.
All right. So then in essence, the hospice vet can make a good recommendation based on their experience to the primary care veterinarian, who then could advise the client.
Correct.
Okay.
Here's another good question that relates to this conversation. So this comes from a vet tech who's attending today. Have vets already accepted that VCPR cannot be established by technology or having a local vet tech or nurse aid in the collection of physical assessments? Couldn't the accountability of not making a diagnosis when there isn't enough to make one on the individual vets? So do you want me to repeat any of that? It's a lot. So have vets already accepted that the VCPR cannot be established by technology? Correct. Or by having a local vet tech or nurse aid in the collection of the physical assessments? Part one.
If the what it's saying is who would be liable if there's a problem? Is that what you're getting at from a legal standpoint?
So Ken can jump in. It's his question. So Ken,
feel free, folks, to, if you have a question that I'm not stating specifically, feel free, Ken, jump in or.
Hi, can you guys hear me okay?
Yeah.
Yes.
Ken.
Okay. So my basic question is it a known fact or accepted truth already that there are no technology means that would be able to supplement a physical exam? Because I think that's what the core argument regarding whether you can establish VCPR or not is there.
If the technological uses are those coming from the hospital, the doctor of that patient, then it's totally fine. But there has to have been a pre-established VCPR. Now, if I would take such a call and let's say, wanted to throw my 2 cents in and use some sort of technology, maybe one of those activity monitor collars or something like that, that's also monitoring heart rate and respiration rate and temperature, and they're out there. Could I use that and use that to make a diagnosis? The answer is no. But can their own doctor use it? Absolutely.
And I guess, I feel like the debate out there still is whether the VCPR could be established by remote means or not. And that conversation is still out there.
Correct.
And
I at this point, and I've been, as we all know, I think you need the doctor's hands or relationship on that pet. If I can tell you stories galore, very smart people, a judge, for example, who I asked her to feel her cat, and it's my patient, her cat's bladder to see if the cat was possibly blocked. And she said, no, I said, I told her where to do it, how to do it. And she said, no, I don't feel anything. I said, I'll bring the cat in. The bladder was the size of a melon. So clearly we need the expert's hands to do that. And I think that's why the developing that relationship is really critical before we resort to just technology.
But I believe that in that particular situation, that would be an example of a case that you wouldn't leave it to remote means to find that information. You wouldn't want the owner to give you that information. You wouldn't. Correct. There's no mechanism to measure the size of the bladder or anything like that. But for the cases that you are able to make a sound diagnosis with the limited information that comes from remote means, wouldn't that be possible? And I think that that comes back to one of the other people's questions that asked, what about the people who can't come in to establish that VCPR to begin with, that isn't going to get follow-up care or doesn't come in to begin with because they're unable to, and we're missing those people.
And that's where the house call practice comes
Jeff,
in.
Really quick, we are at our 30-minute mark, and we do need to allow people.
It goes fast, doesn't it?
It does. For those, Dr. Werber is going to stay on for an additional 10 minutes, but we did promise folks that they could be in and out in 30 minutes. So for those and the remaining questions that are on the side, we will make sure are definitely answered and submitted to everybody. But we will continue this conversation for 10 more minutes, but everyone is allowed to exit at will. So don't feel like you're, oh gosh, if I drop off, it's a bad thing. That's part of the Bridge Club. We want to keep this to the 30 minutes. So at this point, we'll let Dr. Werber continue his answer, but please do feel free if you need to drop off.
All right. Anyway, for those of you that have to sign off, thank you so much. It's great. Now, for those of you that are going to be at VMX, formerly NAVC, the Bridge Club is going to have its kickoff big event Saturday night. So make sure to let Brenda or Catherine know that you'll be at VMX, and we'd love to have you there, meet face to face. I think it'll be a great opportunity to feel really good about this new opportunity that's before us, to share information, talk to each other, get to know each other. And anyway, look for us at VMX and Saturday night at the Bridge Club. Catherine, where's the reception going to be?
So it's actually going to be in the Hyatt in the penthouse. And so we will be emailing out the direct address because we don't get that until we just check in, but it's in the Hyatt. Great.
Hopefully we'll see any of you there that are going to be at VMX. And any other questions? Hi, Bruce, by the way. How you doing?
Good.
So my thing about Concierge. So, again, this was my take because I do agree that sometimes we need to be there. I think Concierge is going to, well, once you go, if you're a concierge practitioner that is willing to do a house call and charge appropriately for it, then once you get there and you have put your hands on that animal, you have listened to the chest, you've done your palpation, you've gotten your history, now that you have a VCPR. So now you can do anything you want. And especially for critically ill animals anyway, I would be very nervous without either speaking directly to the primary veterinarian or just going by on the owner, or even looking at the animal on a phone to make a diagnosis to the point of wanting to prescribe something or recommend a treatment. So I think that the VCPR for veterinary is essential. For the same reason why we all soap our files. What do many of us do with S? Okay, the S from soap. Okay. So, you can't ask that, with a person, so Mrs. Smith, how are you feeling today? How is that, that pain in your shoulder? All right. So it's subjective. It's the owner's subjectivity. And then we do the objective. We start doing our own exam. How do you go in and ask the cat or dog or horse or whatever it is, how you feeling today? Now, we can take a guess based on their energy, based on their activity, but most of us put SO together because it's really all the objective. So I think that because of that, we are at a major disadvantage. And that's why I think that physical exam, that hands-on exam still remains essential, not when it comes to advice, not when it comes to, I think this is what's going on. Those of us that have a lot of practice years behind us, could say that with confidence. I can diagnose half the things I diagnose without any tests, just because of wisdom. You see it after 30 years, you see a lot. But I will tell you that to really make a diagnosis, I don't know if I'd want to do that just based on electronic media. Any points anyone want to chime in? What do you think, Ken? You see where I'm coming from?
He's unmuting.
Yep, and sorry, there's some dogs in the lobby, but yes, no, I totally get that conversation. I think it's worth exploring it. At least being able to utilize the technology for patients that we've already established that VCPR with is the first step, and I think we can see how things go from there. I would think.
And I agree. And I think there are great collars out there. We use it with our company, collar that can measure, again, how accurate, who knows, but it does a decent job, heart rate, temperature, respiration rate, activity. And you're right, Ken, I think if we already know the patient and know the client, it's a little easier to maybe use technology, but I would not want to, and I've been doing this, I have a lot of experience. I would even be a little nervous for that patient I've never seen before. To start using that type of technology. It's just not proven enough yet to make me feel good. And not even from a legal standpoint. A legal standpoint, I'd be buried. But I'm talking about from a standpoint of just confidence as a practitioner, where I want to put my signature on that diagnosis or on that treatment recommendation. The answer is still not yet. I don't think technology is advanced enough yet for us to do that.
I think that probably brings us to our end. I want to thank absolutely everyone for this. We have our next one is next week with Stacy Purcell, who is also here today. We will be having Ken talk about the veterinary nurse initiative coming up here shortly. So we've got some really great stimulating topics coming along the way. I do hope that we can see you all at VMX. And with that, we are going to be sending you guys the link to this video, as well as a little survey to help give us some feedback as we're continuing to pilot and bringing our dream to life to enable professionals to connect, learn, engage, and grow. And so that is what the Bridge Club is all about. So I really want to thank all of you for coming. It means the world to both Brenda and I. And Dr. Jeff, thank you so much for being our guinea pig in this whole thing. I think that it was a very robust conversation. We have many questions for you yet to still answer, and we will be sending those out as well. But everybody, cheers, and thank you so much for what a great day this has been already. Cheers.
Thank you. Thank you.
Wow.
Great being here. Hope to meet some of you at VMX.
Absolutely.